My name is Damilola Jolayemi. I'm with the Center for Behavioral and Addiction Medicine at UCLA. This is the Case-Based Learning Collaborative on Stimulants series, and it happens every first and third Fridays at 12 p.m. to 1 p.m. Pacific time. This session is hosted by CBAM, which is the Center for Behavioral and Addiction Medicine at the UCLA Department of Family Medicine, also in close partnership with the Los Angeles County Substance Abuse Prevention and Control Program and the University of Texas Southwestern Clinical Trials Network, Big Southwest Node. And so we are pleased to present a session today, a very, very interesting session. But before we do that, I'll go over just housekeeping items. Next slide, please. These are the objectives for the session, which we've seen so many times, so I'll skip this. Next slide. All right, so the format today, in terms of Q&A, we ask that you use the Q&A option for questions and the chat for comments. Feel free to say hi in the comments and tell us who you are, where you're joining from. You can also put comments in the chat. If you cannot find the Q&A, please feel free to use the chat for questions as well. During the case discussions, we ask that you participate. You can turn on your camera, you can unmute your mic, or use the chat on Q&A to just respond to some of the prompts that the speakers may be providing today. For the CME credits, please ensure to attend the full lecture and complete the evaluations that will be provided for you via email. Evaluations are not after each lecture anymore, so we will do group evaluations. So just keep an eye out for that information. Closed captioning is also enabled, and feel free to use it. Past presentations are available on the CBAM website for presentations that we have the permission to record and share. Our next session is in 2 weeks, which is Friday, February 16, 2024, and this is the title. This is around substance use, violence, and HIV/AIDS syndemic among women who use drugs. And so please look out for that flyer that will be going out sometime next week. All right, next slide, please. This is our disclosure slide, just showing our disclosures for the planners for this activity. All right, so without further ado, I'm going to go ahead and invite Dr. Julio Meza, who is the co-chair for the series, to introduce our speakers.
Okay, thank you very much. And thank you everyone for joining. Today, I'm really excited, as you've noticed, right, definitely how our program has evolved as we go, right? Definitely we started with some really cool didactics more than anything, and a lot of really excellent learning based on studies and so forth. And now we're getting more into case-based learning, which has been a really great experience in our last few meetings that we have had together. Today we have two excellent speakers to give us more of that base, the knowledge base of what's on the field and what on the field we can do and try to implement. Allow me to introduce first Dr. Chelsea Chover. She is an assistant professor in residency at the David Geffen School of Medicine at UCLA. She directs epidemiology, policy, and implementation in our laboratory. She completed her PhD in epidemiology at the UCLA Fielding School for Public Health, followed by a postdoctoral fellowship in psychiatry and behavioral sciences at Stanford University. Alongside with her academic research, Dr. Chover has worked with local government, community clinics, and policy advising capacities, all of which inform her team approach to urgent and complex public health problems. So definitely a lot of knowledge in these areas. The EPI lab's work unites quantitative and qualitative data and analysis with community-based participatory research on overdose, substance use disorders, infectious diseases, and homelessness. Dr. Chover is currently funded by the National Institute of Drug Abuse and Centers for Disease Control and Prevention to improve overdose surveillance in Los Angeles, and operates a drug check-in program and also syringe exchange programs. Also, alongside with Dr. Chover, we're going to have definitely Jordan Spoliansky. He is on the Skid Row support and training team for Los Angeles County, the County of the Department of Public Health Services. Supports people facing various social and health-related challenges, many of whom are also experiencing homelessness. Jordan provides training and modeling to the interim housing providers, medical providers, outreach teams, and field medicine teams as well on a variety of topics, including harm reduction, trauma-informed care, and navigating the network of interim housing services in LA. As you know, homelessness definitely has skyrocketed in the past few years. So definitely Jordan has been quite important and a portion of the cornerstone of what we do in Los Angeles. Jordan also loves family and making some music. I had the chance to read some articles about him. I'll ask him later if we have some time, okay? So without further ado, definitely Dr. Shover and Jordan Spoliansky.
Wonderful. Let me just pull up my slides to start. And thank you for that wonderful introduction, Dr. Mesa. Okay, let me make sure I'm doing this right. Yes, okay. All right. Are you all able to see just my slide?
Can you hit slideshow?
I did. Okay, let me do it again. This happened last time too. Okay. Slideshow from beginning. Yep. It's not gonna work. Okay. Let's try one more time. I'm gonna stop and restart, but in the meantime, I mean, Dr. Meza gave a really good introduction. So I'm just gonna say a little bit about what's more relevant to what we're going to be talking about today in terms of who I am, and I'll let Jordan chime in with his stuff. But yeah, basically, I am the principal investigator of a drug checking program that we started about a year ago. And we are located with a few different syringe services programs in LA. And so this is really community partnered research. And that's what we're going to talk about. But I seem to have some sort of Zoom problem recurrently where I just can't share my slides.
I have a suggestion that probably won't work, but if you press slideshow and then go from current slide, will it bypass the from beginning?
Yeah, let me see. No.
No, worth a shot, I guess. But...
Okay. Well, all right. Can you share the slides?
Yeah, I have them
Okay.
available. I
Yeah.
could give it a
Okay.
try.
Great.
Do
Sorry.
I have sharing privileges?
Yes, you can.
Okay.
No worries.
Okay. All right. Well, I think one thing, I mean, I think if I were attending this talk, while Jordan's pulling up, I'll just sort of give this part. If I were attending this talk and I saw the title, I was like, oh, one person is going to talk about drug checking and one person is going to talk about trauma-informed care and case management. I'd say, okay, I know those are both parts of harm reduction, but I'm not sure I totally see the connection. Awesome. Thank you for getting it up. But I think we'll be weaving in the connection as we go, but I think really the point is that broadly harm reduction is, as a philosophy, is a way to align yourself with the goals people have, and drug checking is just a really good example of that. And I give full credit to Jordan for framing it that way, because I've been thinking like, yeah, it's related, but I don't totally know how to put that into words. You want to just introduce yourself a little bit?
Sure. Hi, everybody. Thank you so much for having me here. It's an honor to be here with Dr. Shover. And thank you, Dr. Mesa, for that introduction. Happy to talk music later for sure. My name is Jordan Spoliansky. I work specifically for Housing for Health, which is a community program of DHS here specific to Skid Row. I do training and support in the interim housing sites. For those of you that might not know what interim housing sites are, that like homeless shelters, places for people to seek shelter that are experiencing street homelessness. I do train on harm reduction and trauma-informed care, motivational interviewing, various evidence-based practices that are very useful in this field, but also I do a lot of modeling and just sort of hands-on work with clients in and out of the interim housing. So people experiencing unsheltered homelessness and sheltered homelessness, people experiencing substance use disorder, various health concerns. So yeah, and one of the realizations that I've come to through collaborating, having the honor and privilege of collaborating with Dr. Shover, is that harm reduction is really a way of aligning ourselves and as advocates for people experiencing all of these hardships, whereas a lot of times the people experiencing these hardships are mostly confronted with sort of isolation, penalty, alienation, where harm reduction gives us the opportunity to sit alongside and advocate from that perspective.
Cool. Thank you. I'm going to start talking about drug checking, but like, please call me Chelsea. Everyone can call me Chelsea today. I feel weird about being, last name. But yeah, Jordan and I have been friends for a while. And so I think that it's been cool to be able to think through these things and, work together in that way. Let's have next slide, which I think is, yeah. So this is just a picture of our drug checking project at one of the syringe services programs. I'm specifically being careful not to name exactly who the partners are or where we're doing it, but we do have a website where people can go to find that information. And as we get a little more clarity, drug checking in the context of a syringe service program in the state of California is explicitly legal, but unfortunately, it remains illegal to, for example, bring your drugs to check. And so in the interest of protecting participants, we are pretty discreet about exactly where we operate. But I'm comfortable saying that we have regular services in Hollywood and East LA, and we've done a lot of drug checking downtown as well. But these are my two staff, Ruby Romero and Caitlin Molina, out in the field in one of our early days with our portable spectrometer. And then on the other side of the slide is just showing how we provide results for people. It is intentionally very low tech looking and not official and not a big printout because we want it to be something that someone can, stuff in their pocket or throw away or just not raise any questions if their belongings happen to get searched or seen by someone else. If it were to say like, this is the official report of what's in your illegal drugs by UCLA, that seems like a problem. But this index card that just says methamphetamine HCl, it's less, I think that's less concerning for a lot of people to be carrying around. And this was a recommendation from one of the communities of drug checking workers and researchers as far as like best practices for how to give people their results. But yeah, back to what we actually do. So someone comes to the syringe services program, we ask people to bring a sample of about the size of a grain of rice. We really do want it to be a residue, very small amount. And that's both because that's all we need to test. And also to minimize the risk of if they were to get stopped, that they're not going to have enough on them that they, have bad consequences. But the first thing we do is we prepare the sample, just scoop out about 10 micrograms. We've got these special little tiny scoops for that, and put it on the spectrometer. And that basically shines a light through the drug sample, which creates a unique spectrograph, just like a unique line that corresponds to that particular substance, and tells us what is in it. Unfortunately, the updated version of my slides had some spectra, but I did not have those, so we can pull some up later. Sorry about that. We go for the first, we run through the spectrometer and it will match the spectra up with what it likely contains. It's looking for main components of the sample. It's checking it against the libraries that have thousands of different chemicals and compounds and substances. And if it's present in the sample at 5% or more, this is probably going to see it. Now, unfortunately, it does not get down on those really low level things. And for something like fentanyl, something that's there at less than 5% can still be enough to cause an overdose or other negative health effects. So we also do test strips at the same time. So we run it through the spectrometer. We're kind of talking to people as we're doing this. We do collect an anonymous survey. It's all optional, and sometimes people just decline everything, which is fine. We still check their drugs. But what we're asking about is like, what do you think this is? Where did you get it? Not very specifically, just like what part of town, what zip code, because we want to understand drug supply trends. In a place as large as Los Angeles, the drug supply is really different in, say, Hollywood versus East LA, which are the two main places we're currently operating, versus downtown where we were doing it for a while. And then we run the test strips. We use fentanyl test strips, xylazine test strips. We also use benzodiazepine and methamphetamine test strips. We can talk more about those as options, but basically they're all things that were, or except for xylazine, they were things that were created as urine drug screenings, but actually do work to test the drugs themselves. And we're working on a study validating that for the non-fentanyl ones. The fentanyl ones, it's like well established that it works to test fentanyl, as probably all of you know. Next slide, please. Oh, and then the last, next slide. But the last step we do is we take a swab of just the residues. We just pass this big Q-tip over the drug, if it's like a powder or a pill or just on the spectrometer. And we mail that off for testing with something called direct analysis in real-time mass spectroscopy, which is a laboratory-based test that can identify small molecules, which, I'm not that kind of scientist. So I always have to ask, like, oh, is this big or small? But it's mostly, they can identify 1,300 different street drugs, prescription medications, and common adulterants like caffeine, but not bulky molecules like sugar, which I didn't know that. I was just like, oh, okay. So sugar is big, caffeine is small, and it can identify lots of different things down to a fraction of a percent. So the DART is super direct analysis real time, or DART. It's super sensitive, but the results, because we're mailing it to a lab, take a few weeks to get back. So basically, what we're doing is we're giving people the results right there in the field. The whole process of testing someone's drugs in the field takes anywhere from 5 minutes for a straightforward sample. That's something that we see a lot of. I guess, spoiler, in Los Angeles County, the vast majority of methamphetamine is just meth, at least that we've seen. It's, it doesn't show up as other stuff. Sometimes there'll be a little bit of a filler. But for more complicated things, like some of the fentanyl analogs will show up with like 5 different other things, and that will take longer. And so then that service might take half an hour. And yeah, this on the one side is our little tent, is like, that's our mobile, kind of our compact outdoor mobile setup. And then on the other side is what we think of as drug checking light, which is what we want to do in situations where it's not practical or possible to bring the whole spectrometer. I'm not going to get into the details of the spectrometer, but basically it's very finicky. It's also really expensive. They're like $35,000, and just as important as the fact that they're really expensive, getting them serviced and repaired is a huge, long time effort. And also, if you set it up on a table and you happen to bump the table, you have to recalibrate it. So like if you're in a setting where you're really moving around, like truly mobile, it's not practical for that. But that's part of the reason we're trying to validate some of the methods with the test strips, because those can be used in a much broader range of situations and by a much broader, range of people. You don't need to know how to use a spectrometer, which is, you can learn. I learned, I don't know about that, but there's a learning curve. Next slide. Oh, this is just how we prep the sample for confirmatory testing, and we're able to do some quantitative testing, which is to identify what percentage of a sample is a given drug. So what percentage of the sample is methamphetamine versus, say, caffeine. Next slide. Oh, and this is the lab, the National Institute on Standards and Technology, that does the DART mass spectrometry testing. And Jordan and I actually had a chance to tour it last week. We were in town for an NIH conference. We got to tour it, and so the lab staff are showing us all the machines and also running a sample over on the side. It's really, the DART technology is really fast. I think the other important thing I forgot to mention about this is that because it's a federal lab, at least at this time, it's free. So if you're deep in drug checking world, confirmatory lab testing is something that really drives up the cost of operating a project. I mean, the spectrometer itself is super expensive. You have to hire someone to run it too. But the confirmatory testing can run you in the order of like $150 per sample if you go with many of the lab options that are available. And there's some labs that'll offer a reduced rate for community-based or harm reduction organizations, but we like NIST because they're pretty fast and the great price of free. Next slide. And I, of course, if you reach out, my email's on the last slide. I'm also easy to Google. I'm happy to connect you if you're here from another program, if you're interested in also connecting with NIST to do testing on your own. They're very excited about having West Coast collaborators. So why do people who use stimulants check their drugs? We, as part of that anonymous survey, we asked people if they've tried the sample before they brought it, to just sort of try to understand what are people's motivations for using this. Because when we started the program, I guess part of the goal, it was an implementation science project, was to see, will people even use this? Will people participate in this? And no, definitely, like, sometimes the first time we'd meet someone, they'd say like, oh, I think you guys are, I think you're just trying to like trap me. I don't want to give you any of my drugs. And I was like, that's totally fine. And then the next week they'd come back and be like, oh, like, you guys are back. Like, I think you're probably okay. Like, here, can you test this for me? But the reasons people, there's a lot of different reasons people bring their drugs to drug checking. This first one is a person who shared that, originally she brought some fentanyl to check, and she shared that originally she didn't want to use fentanyl, but then it started showing up in her meth, and she didn't have as good of an experience when she was using just meth by itself. And so now she's got a new batch of fentanyl that she wants to check what's in it, because she said the last time burned her throat and lungs when she smoked it. Oh, here's one, just shout out to the UCLA Vine Street Research Clinic. Someone came because they said that a test found fentanyl in their system, and they wasn't something that they use on purpose or no. The sample that they happened to bring was only methamphetamine, but that's a reason. Often people are bringing stuff because they suspect there's something wrong with it based on the experience they're having, or something different about it. Next slide. Okay, this is kind of a longer thing where someone is basically saying, this is another thing, like, so a lot of times people bring their drugs because they're concerned that something's different about it, that it's not, it's causing unwanted side effects. The other sort of big bucket of reasons that Ruby, who's one of our project staff, who's I think listening today, identified, was that another reason is like people are just concerned about the potency. So in this case was somebody who was saying, I'm bringing this because it doesn't feel as strong anymore. I used to, I'm taking this meth as a way to self-treat my ADHD. And this conversation is sort of rapport building that we could have at this drug checking conversation was a way to help link this person to a clinic actually located in Skid Row that they could go to for things like contingency management and just other services. So I think part of it is that, like, when we're checking someone's drugs, it's often, it's a few people, there's a lot, it's we're sitting there waiting for this machine to do its thing, and that's a good time to talk with people, and people open up. But we do have a lot of repeat clients too. And then this other one was just a similar thing where someone said, it didn't feel as strong, it felt different, it looked different. Yeah. Next slide. Real quick, quantitative results. I just think this is super interesting. So we have not done a lot of quantitative testing yet, and part of that is because it takes a lot longer. For the DART analysis I showed you, that takes about, they did it in front of us, it takes about a minute. For quantitative testing, to break it down by the percentage of different components, it takes more like 20 or 30 minutes a sample. And so the lab, isn't able to do as many. So we've only had a few quants come back. But these are 5 different samples of methamphetamine that came in on 1 week in September. And they came from different parts of the county, some from some at our Hollywood site, some at East LA, some from downtown, some from more like the Westlake MacArthur Park. All came back at the point of service testing as methamphetamine. All clearly were methamphetamine. Let's go next slide. And then we got the quantitative results on them. So this first one that had come from Westlake, the crystal and powder from Westlake had a very high potency or purity at almost 70%, compared to this powder from, I guess we didn't actually know where this powder came from because the person just didn't provide any information about it, but they brought it to the East LA location, which I think probably means it's from somewhere in that part of the county. And that's, a lot lower at 23%. And so when we think about it, somebody using methamphetamine, it's a big difference versus this last one, this pressed pill that was, looked kind of looked like an Adderall, but was very poor quality pressed pill, had 2.7% meth. And then this like trace of ketamine, which, this is kind of the flag for drug checking, is very complicated because that's probably not an amount to have a clinical meaningful effect. And in fact, just might be cross-contamination. But anyway, that's a huge variation in how much, if you just say, oh, someone's using meth that they're getting on the street, that's varies a ton in what that might actually be. So next slide, I think we're going to transition to case. Yes, great.
All right, I think I'm going to take over here for this case study. This is an experience that this is one of the experiences that I wanted to talk about today. This is a person who reported polysubstance use, presents with severe mental illness, and is trying to access resources in interim housing. So this woman in her 30s is experiencing sheltered homelessness. So she is in an interim housing site, and she does report polysubstance use, including meth use. This was on one of my visits to an interim housing site where I was going to do some training and some modeling with some of the case management staff, and a case manager who I got to know came up to me and said, hey, look what I got. I don't know what to make of this. The case manager was a little frustrated, kind of a little bit fed up with like, what am I supposed to do with this? And it was a letter from a newly assigned client on her caseload. And so I say, hey, let's take a look at the letter, see what we can get from it, and tried to kind of like reframe receiving this letter in a positive light of kind of like, hey, look, your client's reaching out to you. And yeah, I can see that this letter might be a little bit hard to understand. And just to give you some context, the letter was kind of had some, information, and one portion of the paper might have been like some numbers, and then the other sort of side of the paper had some writing that was kind of maybe, a little bit hard to understand and disorganized. But we sort of sat down and pieced it all together, and it turned out that her client was actually like reaching out to her case manager to try to get linked to health services, to a clinic, to make an appointment for the doctor. So we kind of sat down, reframed the letter in a positive light, went through it, and it was a really good thing. So I was like, hey, maybe we should go check in with this client and let her know we received her letter, and just kind of thank her for reaching out and start to get the ball rolling on making that connection to services. This is a really good opportunity to build rapport and to get to know your new client and so on. So sort of what Dr. Shover was talking about as what harm reduction is, as reframing things and aligning ourselves with the people that are asking for the help or that need the services. This is how we use the letter to align ourselves with this person's client. So we went up to the client's room, and it actually turned out that this client had also been issued like a behavioral adjustment contract, like hey, your room is dirty and you need to start cleaning your room more regularly, so let's make an agreement to do that. And it was actually kind of a point of contention with the case manager, but coming up with the letter, letting her know that she received it and getting the ball rolling on that was like a really cool access point in the conversation to go, hey, can we also start working on collaborating to clean up some of the room, as we also start to kind of work on getting you connected to services. So it had another little add-on bonus of bringing up something that is usually punitive and usually kind of a point of contention and gets in the way of advocacy in the light of collaboration, which harm reduction in general, not only around substance use disorder, but sort of harm reduction in general scope is that's what it does. So I'll pass it back to Chelsea here.
Yeah, I see that there was one question in the Q&A. So thanks for that. And we can take questions through how people have them. There was a question in the Q&A about if this tests only for stimulants or other synthetic drugs. The portable spectrometer tests for everything, including a lot of things that are not drugs. So if you put something through, we've gotten it before back when we had a pill that was clearly full of some kind of starch, and it'll suggest possible options. And so one of the options it suggested was Hungry Jack mashed potatoes. I was like, I don't think that's right. But it is very accurate. It's very good at identifying illicit drugs and prescription medications. And then the DART send-off testing can identify about 1,300 different compounds as long as the molecules are small. Now the test strips, though, those are all specific to, they identify usually just the one drug. I mean, meth test strips we're finding through our validation studies also turn up positive for MDMA, which makes sense given the chemical structure. But Yeah, those are all just specific to the one type of drug at a time. Okay, so this is a small drug checking case study of just a sample we got that was sort of unusual and interesting and illustrates a bigger theme, I guess, that we get here in LA. So we got this, someone brought in a purple sticky rock. When you kind of squish it, it felt like tar, like heroin, but when it was on its own, it was just like purple with some green flecks. This person had bought this downtown, even though he lived pretty far away from the downtown Skid Row area in a single room occupancy building. So we ran it through the spectrometer, came back as fentanyl and mannitol, and the person brought it because they thought it was going to be fentanyl with xylazine. They thought it was trank dope. We did not find xylazine in it. When we did the test strips on it, though, because at the time we were doing xylazine test strips by then, it came back negative, and the test strip for methamphetamine came back positive. And I'm like, oh, that's interesting, because one of the reasons I was interested in trying to start a drug checking program in LA was because with looking at the epidemiology of drug-related deaths here, we see this massive rise in deaths that involve both fentanyl and methamphetamine. And of course, lots of people use both together or at different times of the day. But I wanted to understand, is there an element of, of fentanyl ending up in the meth supply? For the most part, that's not something we found. I do have one sort of counterexample a little later, but what we do see stuff like this pretty often, where the sample is brought in as fentanyl, but it actually contains a little bit of meth. And so in this case, the meth didn't show up on the FTIR, so that means it was probably there at a low concentration, like less than 5%. And then in our send out testing, they did confirm that it was fentanyl, methamphetamine, and then a precursor for fentanyl, 4A and PP. So this is just something we see a lot, where samples come in as fentanyl, they've got a little bit of methamphetamine on board. And so part of in response to this, I collaborate with some ethnographers, and one of the things I was chatting with them about it, and they're like, well, you should really start asking people when they have a result like this, just trying to understand why that's happening. I mean, there's lots of possible reasons. Like, it could just be that the person uses both and keeps them together. Or it could be that there's actually meth ending up in the fentanyl somewhere in the manufacturing. So that's one of our ongoing things we're trying to get a better understanding of, because we're seeing about a quarter of the fentanyl samples have methamphetamine on board too. That's it. This
Kelsey,
yeah.
I have a question. So
Yeah.
Can you talk a little bit about the frequency that you're seeing the fentanyl being tagged with stimulants here? Because we're hearing that this is a new thing in San Francisco, particularly with the cocaine out there, where people are coming in thinking they're using cocaine. They get their urine tested and it's got fentanyl in it. And so can you talk a little bit about, are you seeing an increase in this? Are you keeping notes on this? What do you think this is real, or is this something that's just like you said, like people keeping their drugs together, and it's just a exposure thing that way?
Yeah, that's a great question. Also, I will answer it. And also, Jordan, if you have any thoughts on this, I want to hear them too. So basically, this way of samples that come in as fentanyl that have stimulants, and it's pretty much always meth, that have meth on board. I've run it a few times, but it's somewhere between 20 to 30% of our fentanyl samples also test positive for meth, and it's almost always at a low level because it doesn't show up on the FTIR. That seems super common. And so for a while, we were only it was only coming up when we got the send out results back. So we weren't able to ask people in the moment about it. But now we're being more proactive with always doing the meth strip so that we can ask people when it comes to a positive, we can say, oh, this meth strip came back positive. Is that something you also use? And just have a conversation about it. Like what, because usually people, and sometimes people just say, oh yeah, I keep my meth and my fentanyl together. And we're like, okay, that explains it. But other times might be more uncertain. The other way of fentanyl showing up in meth or cocaine, I know it happens. I personally know people who have overdosed or died from that happening. I think it's really rare. Actually, when I was pulling the data for this presentation, and I think it's my next case study, is the one example I have found that seems like it was actually a methamphetamine product that had some amount of fentanyl in it, that the person didn't say when they came, hey, this is meth with some fentanyl in it, which is also something people do bring us pretty regularly. So that's kind of, we see it's usually when there's a stimulant that has fentanyl on board. All but this one case I'm going to show you so far has been someone saying, hey, can you check my meth? There's probably some fentanyl in it too, because I use both. And that's when we found it. So yeah, I don't know. I don't think that's something that's happening more often. We've only seen it once out of, done like about 500, probably 520 drug product samples since we started.
Yeah, I'll
A
just,
little question, Dr. Shop. Oh, so sorry about that. To both of you, actually. Is there any geographic specificity to this, whether it's the co-use or contamination of fentanyl with stimulants or stimulants with fentanyl? Is there any specific differences in some specific areas of LA compared to other ones? Have you noticed any of that?
I think that's a great question. That's something I'm very interested in trying to parse out. We have only recently gotten what I feel like is probably enough data to look at that in a meaningful way. So stay tuned. Yeah, we're also only operating in 2 sites, although we do get people from all over the place. I don't know, Jordan, what you think about that, because you.
yeah, I just wanted to sort of corroborate what you were saying, is that I in my kind of in the chats that we've had about this, I think contamination sort of makes a lot of sense, especially as polysubstance use is so prevalent and that drugs usually change hands a few times before they wind up getting checked. So I think it's probably kind of reasonable to say that maybe if the person that is having their drugs checked might not use fentanyl, maybe the person that had possession of the sort of the supply beforehand might use, or before that might use fentanyl, because as the drugs change hands, the likelihood that that they might come in contact with somebody who is a polysubstance user is likely pretty high. So
There's a question in the chat about cannabis. Do people bring their cannabis because they're worried about contamination? We've had a couple people bring cannabis. Not really so much that they're worried about fentanyl in cannabis, which, you know, obviously you can put a powder on anything. You could put a powder like fentanyl on cannabis. We've no evidence that's happening in any sort of large or even meaningful scale. But yeah, people do bring their cannabis products. They're often worried about, I mean, this doesn't happen very often, but when it does, it's people who are often worried. Well, sometimes it's just people who have been coming to drug checking for a while and they're like, hey, can you test this also? Just like, will it even work? And it does, surprisingly. And sometimes they're worried about like other kinds of ingredients or unwanted contaminants. We haven't really had people coming in because they're worried about their cannabis having fentanyl in it.
Mhm.
And we've also
Okay.
never found that. And it's broadly not happening.
if I could just, sorry, go ahead.
This is Philip in San Francisco. We have, when we look at our data of patients that were seen by EMS for opioid overdose, over 40% report deny any intentional opioid use. And the stories that are coming out of the interviews with those folks are generally what's happening is that people are picking up a drug that they don't know where it's from necessarily, and they're making a guess as to what it is, or they're with a group of people and they pick up the wrong pipe. So most of the overdose events that we're seeing are mistaken drug. But then you do have a lot of the sort of cross-contamination that clinically isn't so significant, although it makes it hard to enroll people in studies that require them to be opioid negative.
Yeah. Oh, thanks for that. That's interesting, and that totally makes sense. Let's get here. We can go to your next case study.
Okay, so this is another example of someone trying to get connected to healthcare that is a person who uses meth and PCP, and this person has had a very serious hernia that was causing him severe pain over a long period of time, well before I ever got to know him. And I started talking to him a little bit about his experience and kind of his story, and in the capacity as a sort of an outreach worker, getting to know him, building rapport. We kind of just hit it off and became, regular. We'd have regular conversations just about different things. He happened to be really interested in carpentry, and he had been a finished carpenter before, and he sort of told me about his interest in divine sort of design and carpentry, and which led to him sort of talking to me about like these aliens that had come and visited him, and showed him these perfect spaces that were perfectly symmetrical and flush, and how he was sort of like on this pursuit to find spaces like that. And all the while he would also tell me about his this hernia that had been really sort of debilitating for a long period of time. He had a lot of trouble getting around, often in excruciating pain. He had been using meth for like 30 years. He said that he had actually been using meth before it was called meth. He used to call it crank, and that meth had changed a lot and it wasn't as good as it used to be. But he was an IV user for a really long time. So he had a lot of different health problems going on. And so I'd kind of like talk to him about getting treatment for his hernia, because it was obviously causing him a lot of pain. It was but he also told me that he was really afraid to go get treated, because he really felt like medical providers were trying to harm him. So as time went on, we would just have our check-ins and just like kind of chat about whatever the topic of the day was. And I was able to sort of like turn the conversation at times towards like, hey, maybe today's the day we make an appointment. And eventually we got to know each other well enough where I could actually inject some humor into the situation. Like, come on, like this is getting ridiculous. You're obviously in so much pain. Can't I just make an appointment? We call this motivational interviewing. That's like sort of the official name for it. It really is an amazing way of kind of assessing someone's needs and gearing the conversation towards addressing those needs. Another way of thinking about it is just taking a genuine interest in somebody. This guy was really genuinely interesting. He told me about his experience living in the desert for many years, doing crank and laying concrete. His experiences sort of like, meeting a lot of different people in the biker community. So it was very easy for me to take a genuine interest in him, because he had all these amazing stories. But through that rapport building, I was able to actually get him to go get treated. So I booked the appointment. I attended the medical appointments, which is extremely important to provide transportation. I think this is like something that's hugely important, to actually go to the medical appointments, provide the transportation as a really through and through support system, especially for people that are expressing a lot of hesitance to receive care, be it for fear of medical providers harming them, fear of needles, or maybe for whatever reason. So just being there for this person was super helpful, waiting in the waiting room with him and chatting, continuing our conversations in that context, sort of like easing the tension. And then after a couple appointments, he was able to get a referral for an operation to address the hernia, and going with him to that as well. And he got treated, and it was amazing to see his life sort of get better after being treated. So yeah, I'll unless there are any questions, but I'll pass it back to Chelsea.
Yeah, sure. Okay, next slide. Someone asked a question about for test strips, about if factors like water or environmental conditions can change the sensitivity. I answered in chat, but just briefly, the dilution, and this is actually leading in great to this example where we talk about dilution and why why that can be important. So definitely with a substance, if you're testing, you have to add water, unless it's already a liquid, to test it with a test strip. And if you add too much water, that can dilute it too much, so it's not going to show a result even if the compound you're looking for is there. And if you don't add enough water, it can be the high concentration can lead to false positives, which leads to kind of frustrating, just confusing and frustrating situations like this one, where we typically use the stimulant dilution for fentanyl test strips, which is adding about a quarter cup of water for 10 micrograms of the stimulant, or it might be half a cup. But something in that range, depending on how much of the powder we're using. If we're using the full 10 microgram scoop, we'll add half a cup. And if we're using less, we'll do a quarter cup. This person had brought something they thought was methamphetamine. It was kind of shiny, purchased downtown in Skid Row. The spectrometer gave a reading of meth and cocaine freebase, so crack. And the fentanyl test strips that we actually did 2 different brands. That's part of our protocol. Both came back negative, but we were using the stimulant dilution, because if you don't dilute a stimulant when you test it with a fentanyl test strip, it is likely to come back positive even if no fentanyl is there. This also works for a few other common drugs and compounds like Benadryl, like diphenhydramine. And so I actually, every time I have new volunteers or students in the field, we do a demo where we take a Benadryl and just barely dilute it and run a fentanyl test strip, and it always comes back positive. So there are just some chemicals that just cross-react. And so because this is a known issue with methamphetamine, we always dilute it, but then that means that I guess in this case, actually this was our one case of a product that someone brought in as a stimulant that did, when it came back from DART testing, turn up positive for fentanyl as well. So I don't really have a lesson from this except that drug checking is really complicated, and that's partly why we use 3 different methods. But you know, it's very difficult because if we had done a non-diluted fentanyl test strip in the field, we would have assumed it was a false positive. And I know that because we did that with other samples in this setting. And that's what, you know, kind of the takeaway was. The DART testing can detect, one of the trade-offs is that it can detect down to a very small level. So, you know, something, you know, plenty of people don't want, you know, wouldn't want any fentanyl in their drug. Some people don't mind if there's a little bit, but it's hard with qualitative testing to figure that out. Okay. Next. So then I think the last case study is Jordan again, and we only have 10 minutes, so we'll be fast.
I'll be fast. This is unlike the last 2 examples, this is about a person experiencing unsheltered homelessness. This is a woman in her 30s that I got to know who had actually been experiencing homelessness on Skid Row for over 5 years. So chronic homelessness with really minimal interaction or exposure to interim housing sites. I think she said she'd been inside maybe twice in all the years that she'd been, and only for very short periods of time. I was actually introduced to her by somebody who was very close to her, who's another client I had worked with on getting inside, and he sort of vouched for me. She was somebody who's not super trusting of people. She has had to survive on the streets for a long time, and has a tremendous amount of trauma associated with trust and rapport building. So took about 2 months just to sort of get to know her a little bit. I was able to sort of show her that I was in line with her needs really early on by providing some harm reduction, and also by sharing with her that I also have my own personal experience with substance use disorder, which she was pretty shocked to find out, because walking around with a county badge, a lot of people don't expect, hey, this person helping others might have gone through something with substance use disorder as well. So I have all these things working for me. I have somebody vouching for me. I'm utilizing some harm reduction tools to build rapport and align myself. I'm also sharing my own personal experience, which I'm really comfortable doing, because I think that it's it's really powerful to destigmatize substance use disorder by just sharing it with people as if it was any other sort of destigmatized illness that people go through. But after a couple of months of developing a relationship and getting some paperwork done, I was able to start collaborating with her on finding an interim housing placement that really worked for her needs. So this is like a crucial part of the process of getting someone inside that's experiencing street homelessness in a meaningful way, is to really involve them in the process and collaborate with them. Tell me what you need, what you'll feel comfortable with, especially somebody who has been chronically homeless with minimal exposure to interim housing, because there's probably a reason why they are not interested in utilizing the shelter resources. So we were able to work together and find a place that met her needs, which meant she had her own room in this case, which makes a tremendous amount of sense given everything she's been through. And again, like the other example where there's a follow through of service, where I transported her to the interim housing site, attended the complete intake process, and didn't leave until she said, okay, I'm good now. So it's like seeing her room, leaving my number, making sure she just knew that I'm going to be available to her past the point that she's inside. And yeah, it was a really amazing experience to see her get inside.
Thanks. And I know you had mentioned like another sort of complicating or like different aspect of that case, right? Was
Yeah. Thanks for jogging my memory. It actually, so yeah, this person, I don't know if I mentioned this, but yeah, this person was a longtime meth user. And the whole time I'd been working with her, and especially on the day that we were actually going inside, she was including another person in the conversation, a person that I wasn't experiencing or seeing, but somebody else was very much so involved in the process. So she was talking to somebody that wasn't me about me sometimes, about the experience of going inside, about her fears or hesitance to go inside. And this is something that I've experienced with other clients as well. Without pathologizing or diagnosing, this is something that I think can be really challenging for different providers to kind of understand sometimes, or different outreach people to understand. But in my experience, sort of just being there and as the other person in the room, and not really trying too hard to understand it as far as the capacity of the services that I'm offering, has boded well. But yeah, I just sort of was really glad to see her get inside, and as soon as we were through the process, I noticed that once her anxiety sort of went down a little bit, the other person wasn't so much part of the conversation. So for whatever that's worth.
thanks. I don't, you can go to the next slide. And this is maybe just, we don't have time to actually talk about this, but stay tuned because this project is really new and ongoing, but we're also, in addition to the drug checking I talked about, we're also swabbing syringes collected from public sharps disposal bins in MacArthur Park, and through that, which is actually a place where we've, it's, very relevant in Los Angeles as far as understanding the drug supply. But yeah, we've found xylazine in a couple syringes. We actually find, you can see in the picture that interestingly, a lot of the sharps bin are full of syringes that come back as nothing being identified. But my theory for now is that a lot of it is maybe people in the community just needing to dispose of needles, like for use with insulin for diabetes. There's a bunch of little like glucose one-touch tests in there. So anyway, this is super preliminary. We are going to be working on this over the next 6 months at least, getting monthly drop off, like monthly samples of syringes to test to try to do surveillance that way. So anyway, that's last slide, I think, is our emails, so we can just leave on that.
Yeah.
Question last 5 minutes.
Pretty cool stuff, definitely. I do have a question in regards to that last slide that you showed. What's the stability usually of whether it's meth or fentanyl after use? Like, let's say on syringes, right? How long will that stay?
That's a great question that I don't know the answer to. Anyone else here? Scientists in the room? I mean, sorry, that's a bit of a flippant answer. This is a method that has been used in other
Mhm.
places, so I'm
Yeah.
confident that it works pretty well, but I don't know what sort of those bounds are. I actually, yeah, but we are hoping to do a little it's like sub-study of the ones that they don't identify on, trying to see if we can identify any large molecules. So something like insulin is too large to be detected on the DART testing that we send it for. And the amounts here are too small for us to use on our portable spectrometer.
Mhm.
But yeah, I mostly think it's a lot of insulin because of the other like insulin related supplies that we see, but it definitely could be other things. It could also just be people bleaching their syringes before they return them. It could be just totally unused, which, I mean, that would, I'm not, we'd have to kind of understand why, but yeah.
Mhm. Yeah, no, thank you very much. And another thing that was really well mentioned by Jordan is that, some occasions we get contacted not necessarily because the main need of the person seeking help is the substance use disorder. It might be something else, right? And as we know, in my case, some of the things I encounter the most is dental issues, right? Is there a good place to find information of affordable or potentially even free dental care sites around Los Angeles? Because that's on occasions the most common thing that or even after a few days of sobriety, some of my patients tell me, hey, Dr. Mesa, I'm not using X, Y, and Z, but now my tooth hurts, right? With what I was using, whether it's fentanyl, it used to calm my dental pain, right? And I'm like, okay, that sounds a fair thing to mention.
Yeah, so Wesley Health Centers has a great dental program that I've referred people to. I know that, and they have locations, they have a location in Skid Row, but they also have other locations around LA. So
Mm.
that's where I've referred people in the past, and it's gone really well.
Okay, excellent. Thank you so much. And let me see if I see any more questions in the chat. Not at the moment, definitely. So I really appreciate answering all my questions and everything. This was great. And definitely we're going to be expecting to see everyone in our next session as well. I don't know if Yoli has anything else to add.
Well, just to share the next session, thank you again for presenting. This was a great presentation. Thank you, Dr. Meza, for moderating. Our next session is March 1st. I'm going to make a correction to what I had said earlier, which is February 16th, which is today. So our next session is March 1st and same time, and we'll send out an email with more details next week. Thank you all for attending, and feel free to share thank yous and comments in the chat.
Thank you.
Thank you for having us.